gynecologist who practices independently in the Dallas area. And her area of expertise is maternal mental health. And so these are the women who she serves. We so look forward to learning and hearing from all of the insightful information that Dr. Dunwald is going to present to us today. Thank you.
Thank you for having me. I think I'm on now. I appreciate you all showing up today, and thank you so much for your expert help in getting this going too, Marcy. Appreciate it. So I don't see my buttons to navigate. Oh dear. Okay, there we go. Got it. So sorry. So today we're going to talk about the many things, of which there are really many, that women go through in the postpartum period in terms of emotions. Often we think in terms of postpartum depression, and we see with our first slide here, our friendly physician, the woman is talking about, I'm completely overwhelmed, all of the things that people go through. You're up with the baby, husbands or partners are not necessarily on target with their help, you're stuck home all day, and he lumps it all into one category of postpartum depression. But when we're working with women in the real world, we find that postpartum depression is not only a bit of a misnomer, but it just sort of limits our understanding if we think in terms of that. We've talked for a long time about the fact that the range of emotion that women feel postpartum is very much like a spectrum. And by this, I mean that some of these things kind of bleed over into each other rather than being a distinct category anywhere along this range of things that people feel. So we're going to talk about these moving from the blues, which is really normal at the left, over to some of the really more severe and probably things that we hear about the most in terms of psychosis, just because psychosis is so noteworthy, makes good stories for the media. We're going to try and clear up some of that, clarify that as well. So keep this spectrum in line or in mind as we move through the slides and talk about each of these in turn. Okay, so the first is the baby blues, and you can see the symptoms here, which are really typical of what we think about a new mother. Just a lot of crying and tearfulness, maybe a lot of irritability, restlessness, a lot of worry, maybe some difficulty sleeping. And the baby blues are so common as to be considered normal. As many as 80% of new moms have some symptoms in this category, and that is often within the first 2 weeks that a woman might be experiencing some of these things. Up to the first 8 weeks, we can consider that the blues. And with the blues, there is much variability too in terms of what she's experiencing. She won't necessarily be feeling these things all the time, but they will come and go. So she can feel euphoric and really happy one moment, and just like she's managing another moment, and then at another moment she might be exploding in anger at her partner or have a huge amount of anxiety as to whether she can really handle this new responsibility and this new baby. And that then would be what we call the blues. The blues are really related to the rapid fall in hormones that a woman experiences in 48 hours around delivery. And so usually they resolve on their own too within that 6 to 8 weeks, if not sooner. The second category then is what we call normal adjustment. You can see it's still a lot of the same kinds of symptoms that she had before, with that same kind of changeability of symptoms as well. So lots of crying, perhaps lots of irritability, anger, sleep disturbance, lots of worry still. Dysphoria is just negative mood. Fatigue is often a huge piece, so much so that we often talk about that even as a category in and of itself of postpartum exhaustion, because as we all know, sleep deprivation is the way that we torture prisoners to try and get them to break down so we can get them to reveal secrets. And here we are, new moms, being tortured by 6 to 8 pound torturers because we can't get the sleep that we need to be able to renew ourselves and function well. That normal adjustment can go on for 6 to 8 weeks as well, and often to even 3 months, she could still be having some of these feelings. And we consider that she's in this normal adjustment phase. And again, 50% to 80% of new moms are going to have some of these symptoms. It is considered normal if there is still much more positive in her experience of daily life than there is negative. If it moves into the area where she really has more negative than she has positive, then we have moved into our next category. If you recall that spectrum again, we're moving then into, excuse me, let me pause a minute because I wanted to look more specifically at these normal concerns. In the first 2 months, lots of emotional and physical problems that interfered with baby health care. And at 6 months still, you can see women had a lot of problems in terms of feeling stressed and just not being back to themselves in many ways. So again, if at any point the balance tips, we begin to move into these other categories, the first of which is postpartum exhaustion. When a woman is in this category, she doesn't identify as being depressed or anxious. She just identifies as being overwhelmed. She often might not be able to go back to sleep after the baby sleeps. She can't settle down and rest because of her anxiety. And often then we get a lot of physical difficulties, headaches, stomach aches, achiness in general that might be indicative of how any of us would feel, again, if we were not getting the sleep that we need. Usually this does resolve on its own rather than being a clinical entity once the baby starts to sleep and she begins to get more sleep. Though we have to have realistic expectations about this too, because we often think, mothers in particular think, who aren't educated about what to expect, they think, oh, well, the baby slept through the night for 2 nights in a row, or now I'm getting 2 4-hour stretches, I should be fine. When the literature tells us and clinical experience tells us that it takes up to 21 days to recover from sleep deprivation. So if you think about that, in the first life of a child, how often do you get 21 days of sleep in a row? Hence the difficulty in reining in expectations about postpartum exhaustion as well, as she's going to think, what is the matter with me that I am not recovering from this? So if we move across our spectrum here, oh, I'm sorry, I keep forgetting that there's another slide. Okay, so the sleep is key. The research shows us that the more often the baby cried and the more she woke up, the more exhausted she's going to be, that she is not getting that adequate sleep. But her idea about how much sleep she gets, as it says here, perception is key. That's really the critical piece. Women who have the mindset that they do just fine on 5 or 6 hours of sleep aren't going to be nearly as exhausted as those women who feel like their best night is when they get 9 hours, of course, which is just common sense. Okay, so we then move into postpartum depression, which is a term that has been used exhaustively, but we will look at all the variations within this and find that postpartum depression itself, even though women talk about that, and healthcare providers too, talk about that as if it's all one thing, that there are actually lots of different varieties within this. If it's going to be a true sort of depression kind of category, we're going to see any of those normal symptoms that we had before just get worse, where the balance kind of tips, where there are going to be more negative days and hours than positive days. Lots of different research over the years shows from 10 to 20% of new mothers fall into this category, where they are just having more anxiety, irritability, etc., than good days. That 10 to 20% puts postpartum depression in all of its categories into the category of being the most common postpartum complication. So more women get postpartum depression of one of these varieties than get breast infections or thyroiditis or any of the other things that can develop postpartum and be a problem. And across cultures, there is some variation by frequency, with Europe and Australia and the USA having the lowest rates, and then Asia and South America having the highest rates. So one of the categories that we often see that is sort of an offshoot of the generic category of postpartum depression is postpartum panic. She might have panic attacks when she has never had panic attacks before, or if she has had panic attacks before, they might recur. Now, panic attacks are episodes of extreme anxiety, but often the physical symptoms are what she is most tuned into. Dizziness, shaking, difficulty breathing, feeling like she's having a heart attack. Many women with postpartum panic feel like they are actually dying or having hot flashes, and they often present to emergency rooms because of this intense anxiety, and they are really worried about their well-being. Most of the time they are completely fine, rather than that anything is going on that is a medical concern, and it is just the postpartum panic. The panic seems to come out of nowhere. It's not related to any specific episode of anything that's happened, which just makes it even more unnerving. And you can see that with this big category of postpartum panic, that's why we begin to say that the term of postpartum depression is kind of a misnomer, because we have much more anxiety than we have actual typical depression. Women are much more likely to be worried and have difficulty sleeping, even if it's not to this level of postpartum panic, than they are to have the crying and weepiness or not being able to get out of bed that we would think of as a typical kind of depression. Postpartum stress is another category. A woman with postpartum stress might have panic attacks, but in this instance, it's much more likely to be related to some identifiable trauma. That can be a trauma that goes with the birth or something about the baby, or that can be a past event that gets re-triggered by the sort of fight or flight response that gets generated when you were taking care of a new baby and things are not going well. So one example of postpartum stress this way related to a trauma was a woman who had she had an emergency C-section and seemed to recover fine in the hospital and was in the hospital about the 3 days as usual and seemed to be doing well. And when she went home, she began to, about 2 days later, she began to hemorrhage. They rushed her back to the hospital. She had nearly died, and with the loss of blood, but they were able to go in and explore what was going on. And someone, in the process of the emergency C-section, someone had nicked a small blood vessel or artery, and she was fine until she started moving around more, and then she started hemorrhaging. So that was all taken care of. Physically, she recovered. Everything seemed to be okay until maybe 3 months out when she went back to work. And whenever she had a job where she had to travel and drive to remote parts of the state. And whenever she would get more than about 5 or 10 miles away from a major hospital, she would have a panic attack, which of course was terribly unsettling. And we can see that then is related to the event around the birth and fearing being away from a hospital, which again kind of sets the postpartum stress. We see that in comparison to the postpartum panic that we talked about earlier that doesn't have a particular trigger. Another category that we see fairly often, we call postpartum obsessive compulsive disorder. With postpartum obsessive compulsive disorder, women have repetitive intrusive thoughts that they identify as just coming out of the blue. Nothing in particular triggers these thoughts. These thoughts are repulsive and shocking to the woman because she wonders, what's the matter with me if I can have thoughts like this? Let me tell you some examples of these thoughts, which again are many, they repeat often over the course of my career in working with women like this. One is about knives. She might not be able to tolerate seeing the knives because when she sees the knives, it triggers in her mind a picture of the harm that she could do to the baby or to someone else with knives. She'll just get a picture that flashes into her head of this, and she, of course, is horrified, that repulsive and shocking piece. So with those thoughts of knives, she might have to take those knives, lock them in the trunk of the car. Another common one is about drowning the baby. So it might be that the partner has to bathe the baby. The woman is not able to bathe the baby because she gets these flashes of thoughts. Another very common one with kind of the population that I work with, people with two-story homes might feel like they can't walk across the second story because they get a picture of dropping the baby. Anything in the regular everyday course of events can seem to trigger these obsessive thoughts. And a woman, again, is likely to avoid it. But the kind of ritual that we see with hand washing or counting or things like that, with a true obsessive compulsive disorder, we don't see so much. This seems to be much more just about the thoughts in her head and her inability to stop them. And these, of course, are, they're kind of horrifying for us to even talk about them. So I'm gonna talk about them in a little more depth. That again, they are often, and these are sort of criteria that we want to tune into, they are often about everyday objects or activities. Putting the baby in the microwave, drowning the baby when you're bathing the baby, the thoughts about the knives. And women say, it just popped into my head, I don't know where it came from. Women know the thoughts are wrong. That's a very important discriminating piece compared to some of the other entities like postpartum psychosis that we're going to talk about. She's horrified by them and has terrible guilt and shame. What kind of a terrible person am I that I think these things, that these pop into my head? Which, of course, we wonder too. Research has shown us that they are quite common, though, that we see that people have thoughts about harming the baby, other kinds of scary thoughts. I'm sorry that I'm kind of going blank on the percentages here, but I think these are, oh yeah, now I remember what they are. So on the left, the 57% and 95%, those are harming thoughts in postpartum moms. And we compare that to people who are depressed anyway. And those are the facts on the right, the 36% and the 60%, that we see that people have those thoughts quite commonly when they're depressed. Another way that I think is really helpful to think about these harming thoughts that puts it into a more normal kind of category for us all is that most of us can identify with the thought signified by the picture on the lower right of the car hitting the trees. Perhaps you drive around, you're out in the country, you're driving around, you come around a curve and there's a big tree in front of you and you have a flash of what could have happened if you hit the tree. That's so common as to be considered normal, and we've probably all had an experience like that. Another fairly common one that people can identify with is if you are on the freeway and you're driving behind a big truck and it has a big load of logs or poles or something like that, that you might get a flash of thoughts that could let go and what would happen. We've all probably had that experience. Yeah, well, I explained the percentages one more time. Yeah, so that 57% of the numbers on the left are of new moms. So 57% of them are having some thoughts about hurting the baby. And then the bottom part is 95% are having some thoughts about harm somewhere. And then the pictures on the right, the numbers on the right, is 36% of people with depression or of people in general will have some harming thoughts like this at some point in time, and 60% if you're depressed. Okay? Maybe I still didn't make that clear. If you want to email me and I can send you more detail about that, I would be glad to clarify that. The takeaway message, though, rather than worrying about what the numbers is that these thoughts are really common, but that in the postpartum period, people get stuck on them. People with new babies tend to get stuck on them. And I think that the way that we can explain this, let me see if the next slide, if not, I'll come back. Okay. This is how it translates. This might help explain the percentage thing too. So out of 1,000 babies born every day in Texas, 100 moms will have postpartum depression or anxiety. And out of those 100, 41 to 57 of those women will have these harming thoughts. So that's a pretty big percentage. Okay. So let's look at why, because I think this is a very good way to normalize these thoughts for people and for ourselves so that we can worry less about these moms and understand who's going to be a risk and who's not, because that, of course, is the definitive thing that we want to be able to take away is when should I worry and have to intervene. So we stop and think about the role of oxytocin in mothering behavior. Oxytocin is the bonding hormone. Oxytocin surges in the late postpartum period and with birth, and definitely around breastfeeding. We say generally oxytocin is responsible for mothering behavior because if we're in the lab with lab rats and we give oxytocin to adolescent rats that have never had pups, they will start to mother the other pups in the cage. So oxytocin basically turns on mothering behavior. It's the bonding hormone and essential that way. And so that's one piece that we want to just sort of focus in on what oxytocin does in terms of mothering behavior. Then we switch over to some information about oxytocin and its relationship to OCD. That oxytocin at the Yale Obsessive Compulsive Disorder Center, we have seen that people who have true obsessive compulsive disorder, where they're washing their hands till they're raw or they're checking locks or things like that, they have too much oxytocin or a higher level of oxytocin in their cerebral spinal fluid. So that's something we know about people who have obsessive compulsive disorder. When we put those two together, then we can make sense of it, that an essential piece of mothering behavior is, which is why we have the picture of the sort of mama bear turned on here, an essential piece of mothering behavior is being able to protect your young. You can't protect your young if you don't see danger in their world. If you don't have enough oxytocin and can't anticipate or think about danger, you do the sort of thing that we sometimes unfortunately see parents do, of leave the baby in the car and go in the mall and forget the baby was there. Those people don't have enough oxytocin. They are not tuned into danger enough. But people who are on the higher end of the spectrum in terms of oxytocin, much like OCD, they see danger everywhere. So that's an essential factor in being able to protect your children, is seeing it everywhere. So in these moms who have these thoughts about knives or the microwave or things like that, that is what's going on, is they have too much oxytocin, and so they imagine the danger everywhere. And they take that normal ability to see danger and they get stuck on it for some reason. Hopefully that makes sense to people. And I have found this to be a really good explanation to give to women that helps them relax a great deal, because really the mothers that I have seen who have this, the 41 to 57, out of 100 who have these obsessive thoughts, they are really good moms. They are really tuned in. They are over vigilant about protecting their children, and it just gets stuck, which of course again is very disturbing. Okay. So this, of course, becomes the question that we want to ask if we're working with a new mom, as well as reassure moms themselves. Psychosis, which we're going to talk about in a minute in more detail, versus OCD. In OCD, the woman knows that these thoughts are wrong. She knows she shouldn't put her baby in the microwave. She knows that's a bad idea. So the psychological term we use for that is ego dystonic. It doesn't fit with her view of herself, is what that means. Often, a woman with psychosis is going to think that the thoughts that she might be having, such as the famous case of Andrea Yates, she thought her thoughts were a good idea. She thought she really did need to drown her children in order to save them from the devil. So you can see that distinction between being horrified by the thoughts and thinking that they're a good idea. That the thoughts don't fit with who you are, or the thoughts really do fit with who you are, as Andrea Yates did, that she was a caring mom who was trying to save her children from the influence of the devil, which brings us to that next point, the religious element. The other piece about OCD is, again, that it's not strange thinking. It is not based in everyday activities and objects, whereas psychosis is really strange thinking that most anybody, even like a 6-year-old, might understand how strange it is. I'll give an example of that in just a second, but again, let me talk about the final point, is that in OCD, a woman is going to avoid those triggers. And in psychosis, she's going to have a real impulse to act and not be able to avoid those triggers. Okay, so women with OCD do not harm their children. Let me make that really clear. So if you can make the distinction or send the person that you are who might be experiencing these things to a mental health professional who can make the distinction, because it doesn't need to be your responsibility if you are not a mental health professional with that kind of background. Is you want to keep these things in mind as you're talking to somebody and get a professional consultation to determine where somebody is before jumping to the conclusion that she is in psychosis and is likely to hurt her child, because a lot of damage can be done. Needless to say, a lot of damage can be done if a woman has OCD and is not truly a risk to her child, and the assumption is made that she is a risk and Child Protective Services is pulled in and the child is removed from the home. But by the same measure, we don't want a child left in a situation where she really is at risk. So we go back to the question of the strange thinking. Let me give an example that hopefully illustrates this point. One mother who did actually commit infanticide and kill her child and was incarcerated in Texas. She was her in-laws were visiting and she was holding the baby, who was quite young, 2 or 3 weeks old, I think. And her father-in-law, who was just a good old Texas boy, walked through the room and said to her, "You're going to spoil that baby." She took that to mean that she was rotten inside the way that food is rotten, and it would seep out of her because her abdomen was against the baby and spoil the baby in that way. That's the kind of strange thinking that we're talking about in psychosis. So hopefully that's clear. And again, I would be glad to give people more information about this through email if we don't, it's difficult to make some of these distinctions through a webinar, I realize. Okay, so another category as we move on across our spectrum here is postpartum mania. This is very similar to a typical manic kind of episode in which the mother is feeling speeded up and doesn't have much need to sleep and might be really distractible, have the pressured speech and the irritability and excitability that we often see in mania. The thing that's a little different in postpartum mania versus in mania occurring at another point in time is usually there is much more irritability versus kind of the euphoria that you often see. Let me give a couple examples of this, because postpartum mania is usually recognized by family members rather than by the woman herself, compared to all the other categories that we have talked about already. One mom with postpartum mania, her husband came out at 2 in the morning and she was on the little sort of exercise machine exercising at 2 in the morning because she wanted to return to her figure. That's not very typical normal postpartum behavior, but she thought that was fine. Or a partner will come home and there's wet laundry on the couch and the baby's in the swing and there's rice boiling on the stove and she's out washing the car. So that kind of distractibility and jumping all around. Another family reported problems with the mom because, and this was some years ago, it's a little different nowadays, but telephone solicitors would call and she would talk to them at great length because of the pressured speech of postpartum mania. I had another woman who waltzed into the midwife's office and she was like maybe 4 days postpartum, and she was just so excited that she had fit back into her prom dress from 10 or 12 years earlier. So that's the kind of thing that we see in postpartum mania that again gets us to begin to question a woman's judgment. And postpartum mania is a very important thing to pay attention to because it can be mercurial and quickly move into postpartum psychosis, which is our next category. So in postpartum psychosis is the rarest one. It is only 1 to 2 women per 1,000. And it can be any symptoms that we've talked about at the left, I say here, because that would have been our continuum. Any symptoms that we've already talked about, plus significant confusions, hallucinations, and delusions. And this is confusion that is along the order of what I was just giving that example of the young woman who actually did commit infanticide. This is way beyond what day is it or where are my keys that might happen with sleep deprivation. She is seeing things that aren't there. She is hearing things that aren't there. Those are the hallucinations and delusions. She has ideas that aren't accurate, such as Andrea Yates had, that the devil was going to possess her children unless she killed them so that they could go to heaven. Postpartum psychosis, we have determined, probably is a bipolar or manic break, which leads us to re-emphasize that if we see any of those things on the previous slide, any of these kinds of feelings speeded up, that decreased need to sleep, that pressured speech or irritability, that we want to make sure that this woman gets medical attention immediately, because it can flip over here into the psychosis. And in psychosis, she is going to need medical attention. She's going to need 24-hour being watched or in 24-hour care so that she doesn't harm herself or her child. In postpartum psychosis, those symptoms usually show up by day 3. In new moms who had not had a child before, 80% of the time those symptoms showed up in the first 2 weeks. So we can see there is at least a window where we can be watching to make sure that if this is going to happen, that we're going to pay attention to it. Psychosis risk in that immediate 2 or 3 weeks after the baby is born is 22 times more likely than at any other time in a woman's life. If a woman has postpartum psychosis, 5% of the women who end up with psychosis do commit suicide, and 4% may actually kill the child. So you can see again that it's really important to pay attention to. And many then do a sort of a murder-suicide kind of thing, to either kill the child or attempt to kill the child before they kill themselves. And more than a third of those had a prior diagnosis of bipolar, which is again why the manic episode is such a critical piece. There are other things besides the hormonal kinds of pieces that can trigger a psychosis too, such as B12 deficiency, thyroiditis, and substance abuse. But the hypothesis overall is that what is going on that causes psychosis is it's sort of what we call the kindling effect, that a woman with a previous history of previous history of bipolar, as we see here, of 33%, or a family history of bipolar or of psychosis, that genetic predisposition is in there. And the woman, when this hormonal change happens, again, that the hormones fall from the highest they ever are to the lowest they ever are in the 48 hours around delivery, that just triggers sort of the same way if we had some rags soaked with gasoline that were smoldering in a closet, and we opened the door to the closet and air rushed in, it would ignite. That's a similar hormonal thing that's going on here, is that predisposition was in her genetically all along, and the hormonal changes and the stress of delivery and perhaps the sleep deprivation trigger it. Sleep deprivation is often a piece that does trigger it. This is again why bipolar episodes and a woman not needing to sleep needs attention. Probably the only woman I have seen firsthand in my career of 30 years working with this, that's exactly what happened to her. She did have the family history. She went for 3 days without sleeping because she wasn't able to go back to sleep because she was heading into a manic episode. And on the 4th day, she thought she had died and gone to heaven, or gone to purgatory actually, and was trying to get into heaven. So again, we see that religious element and the element too of it not being terribly sensible. We can zero in even more on who is actually at increased risk of infanticide, because of course this is ultimately the most critical thing that we want to prevent in the postpartum period. And these are our factors then, that if a woman has a history of physical or sexual abuse in her early life, if she lacks a lot of memories about her early life, or if she lacks memories about the birth, that's another risk. Depersonalization or derealization. An example of this might be sort of the story that we sometimes hear about a teen mom who, gives birth at the school, delivers a baby in the girls' restroom, and feels like she was outside watching herself and it wasn't real. It was like a dream, like it wasn't really her that was doing this, which enables her to do something like leave the baby in the dumpster because she didn't connect it really with her own personal experience or that it was real. Dissociative hallucinations in particular are a form of that depersonalization or derealization in which she feels like she is out. That is a dissociative hallucination, is what I just referred to in terms of being outside and watching herself. Okay. Denial of pregnancy makes infanticide risk an even bigger issue, again, because of the depersonalization and the derealization. And chronic postpartum depression, which that was the factor that we saw with Andrea Yates, is she had depression with all of these children and it had never really been treated or resolved. So those are the things that we want to be paying attention to in terms of infanticide risk. So we can kind of divide it into categories of infanticide risk, one based on that mental health history with that predisposition based on an abuse history, or the 5 Ds, which are the derealization, depersonalization, dissociation, denial, and depression, or a new episode of bipolar disposition that goes into that genetic predisposition, the sleep deprivation that we've referred to, that hormonal change, and the kindling effect. So a woman who commits infanticide is going to fall into one of these, and we want to pay attention to both of them. But again, this is really rare. It is what makes the news, but that doesn't mean it's not. So it's not likely that it's going to be what you really encounter, but it is really critical to pay attention to. Okay. So this just gives us an example about how variable the thoughts in postpartum depression and anxiety can be. Rather than having an active pattern where we can say, oh, it's this or it's that, if she's eating, she's okay. Maybe she can't stop eating. Maybe she can't eat because she's anxious. Maybe she can't sleep, or maybe she wants to sleep all the time. Maybe she feels worried all the time. She's having scary thoughts. It just gives a good, this slide gives a good idea about how things can be variable, and we want to keep an open mind and encompass all of these possible things. Okay, so prevention, of course, always begins with thinking about who is really at risk, so we can screen and tune in to things like this even during pregnancy. And one of the biggest factors in terms of personal history is, does she have any previous history of depression, anxiety, panic, obsessive thoughts, or mania? That's one really big risk factor, if she has that personal history. That risk factor becomes even more important if she has experienced one of those things during pregnancy, which is why we should be paying attention and asking about these things, not just postpartum, but over the course of the childbearing year. Okay. Another big risk factor, even if she has always been well, is that family history of depression, anxiety, panic, obsessive thoughts, or mania. Many women, in fact, statistically, the first time that a woman usually comes into contact with the mental health system is after the birth of a baby. So that indicates how that family history is key that we want to be watching. And then marital conflict or discontent, or relationship conflict or discontent, especially perceived partner support. We all know that marriages don't get fixed by having babies, that it's a stressor, and tuning into that and noting what kind of relationship is present here and whether the partner can offer some support is critically important. This slide speaks to the etiology or the causes of postpartum depression and anxiety. And we talk about it as being multifactorial. And these are our 3 categories that often we might think about this as sort of a scale with 3, a balanced type scale with 3 pans versus 2. And a woman can have factors primarily in one or in all 3. So the first factor is the biochemical piece. That those hormones, female hormones, change in that 48 hours or 72 hours around delivery. That then changes brain hormones. So we have that right there. The previous history of depression and anxiety would speak to a predisposition to the brain hormones being able to be quickly unbalanced as well. female hormones, PMS if she has a previous history of PMS, PMDD, or of thyroid kinds of issues. Also, if there are hormonal issues, which means that she had to undergo fertility treatment, that would be another risk. A genetic predisposition is part of that biochemical risk, which we talked about in terms of that family history, both with bipolar, with psychosis, and with depression and anxiety in general. The sleep factor that we have referred to, both in terms of exhaustion and also in terms of how sleep deprivation can trigger mania in somebody who is has that family predisposition, and certainly diet, because we've got some research showing that somebody who is eating a healthy diet of fruits and vegetables is much less likely to be at risk than somebody who has a poorer diet. The other thing that I see in terms of this about women in my office is that for certain individuals, we see that a certain diet eating pattern of eliminating carbs, which sometimes women really do to try and get back their figure afterwards, can put her at risk. Animal protein in many people, unopposed by carbs, so if you have like just a chicken breast and a salad or something like that, animal protein can actually decrease serotonin, which is the brain hormone most responsible for well-being and mood. And complex carbs and vegetable protein actually facilitate the production of serotonin and make us feel calmer. So if she's eliminated carbs, it might be that she has increased her risk by making that diet choice, and that's something where I like to try and intervene and encourage people to do that as well. Then there are the external stressors that can contribute to a woman developing this. All kinds of social support sorts of things. For a long time, everybody I had seen with postpartum depression was new to Dallas and had moved either during pregnancy or shortly thereafter. That means they don't have that social support, family illness or loss. I see a lot of women who have, a history of father-in-law has just had a heart attack, mother has just been diagnosed with breast cancer, their favorite grandmother died 2 weeks before the baby was born, all kinds of family stressors that way, finances and socioeconomic status, which of course makes a lot of sense that if we have stresses in terms of more basic needs, that's going to be a problem. Social support, what kind of a network you have, and whether you have a bit of a village to help you with this situation of having a new baby or not. Baby and birth factors are important often too. That's another significant thing. If there is some disability with the baby, or the birth didn't go the way that you wanted it to, we can have a full range of things that might fall in there, and job factors as well. Do you get any maternity leave? Are you constantly on call even though your baby is 2 weeks old? Concerns about if you're going to have to go back to work, you don't want to go back to work, those all fall into that category of external stresses. And then there is the category of internal stresses, which is the more traditional realm of psychotherapy, personality sorts of things that we see. Somebody who has some negative thinking patterns. I see a lot of new moms who have a lot of ideas about perfection and control. Having a new baby is often the first time they come up against the fact that they don't have control over their world in the way that they thought that they did. Because we really can't make these little creatures eat or eliminate or sleep when we think they should. Perfection comes into when moms have ideas about how they should be as moms. That ties right in with expectations too, and the research shows us that the more realistic your expectations are about what new motherhood will be like, the less likely you are to get depressed. We've come a long way in this over the course of the years that I've been working with this, but we still do have sort of the idea that, yeah, I know postpartum, as women refer to it these days, I know postpartum is out there, but I didn't think it was going to happen to me. Just like women think they're not going to be one of those 20% who might end up with a C-section. They don't think they're going to be one of the 10 or 20% who end up with some postpartum depression or anxiety. Self-esteem and confidence overall, if you are concerned that you can't do a good job at this, that's going to really raise a lot of anxiety, because as a culture, we are sort of a mother-blaming culture, and if something goes wrong with the child, we might look to mom first. So she is going to internalize that and have If she has doubts that she can do well, that's going to be an issue. The Wisconsin Perinatal Network likes to say you can't tell by looking. So if we look at our kitty here, is that kitty depressed or is that kitty having a nice nap? And that's often, I think, how new moms cope too, is they put on a happy face when they're visiting the doctor or when family's around, and then they are breaking into sobs or not being able to sleep because of anxiety when nobody else is around. And so for that reason, we would like screening to be fairly universal. Screening to look at, just in terms of an interview kind of screening, if somebody is working with populations of moms, women during pregnancy, we should be asking those questions about what is the state of the relationship? What is the family history regarding these kinds of things? What is the personal history regarding depression and anxiety and bipolar disorder? And how is she feeling during pregnancy? Because again, as we saw several slides back, that is the biggest factor, is those kinds of previous history things. A more formal screening we would like to see mandated everywhere. Some states have moved in this direction. The EPDS is the Edinburgh Postnatal Depression Scale. It is widely available. If you want a resource, you can just go to Google and put in Edinburgh Postnatal Depression Scale, or you can again email me and I can point you in the right direction. It is 62% accurate. It's a simple 10-item pencil and paper questionnaire that women can do, and ideally that is given to them across pregnancy at a couple of times as well as postpartum, so that if we can realize that someone is experiencing these things, of course, that sets the stage to be able to intervene. Okay. There is within the EPDS an anxiety subscale of 3 questions. These are the 3 questions, and some research is showing that these 3 questions might actually be just as good as the whole 10-item scale. So these are questions, even if you weren't doing a formal screening, that if you could work these into an interview kind of format, you might be able to pick up on a lot of women who are experiencing this and not willing to talk about it. So if you are talking with a mom and she is, yes, the question is there a recommended time frame to administer the EPDS postpartum? Yes, I think definitely within 1 week. That was the suggestion. Within the first week, if possible, before she leaves the hospital would be a great thing. And then within 2 to 4 weeks. If we think, though, I think we want to continue to be able to screen too, that often women are done with contact with their nurse midwife or the gynecologist, OB-GYN, by 6 or 8 weeks. And the research tells us that the symptoms are often greatest at about 10 weeks. So ideally, we would have pediatrician screening as well in order to pick up on those women who have already moved out of the regular contact with the birth provider. Okay, so if you're talking with somebody who has some symptoms, one question to look at is, what are the most troublesome symptoms currently? What is really bothering her the most right now to encourage her that maybe she could get some help with that? A very here and now focus is really important, rather than talking with her about what happened, when she was 3 or things like that. We want to focus on paying attention to what she can do to take care of herself right now. And again, tuning into that multifactorial picture is often helpful too. That let her know that this isn't just about a lack of her confidence, but that anybody might be falling apart if they had a new baby and their mother had just been diagnosed with breast cancer, or anybody with a family history might have that predisposition genetically. And so we can take a lot of the guilt away that might be a barrier to getting treatment if we can talk about the full range of factors and what might be going on with her. And I think another question that we want to begin to pay attention to is her current efforts towards self-care. What is she doing to actually try and balance out stresses of being a new mom? These are some warning things that I like people to pay attention to. If she is experiencing any of these things, it's really, really important to get her into a health professional who can help with this. If she feels like the baby doesn't like her or is out to get her, that is obviously a real red flag in terms of bonding with the baby, as well as in terms of her negativity. Secondly, if she's just so irritable and she's mad at everyone, especially at her partner, or if she is just feels like she has a support system and she's been talking about it, but she feels like she's wearing them out and they're getting tired of it, because that's going to make her shut down before she's had a chance to really get to the point where she resolves things. Okay. And if she's had any of these physical symptoms without any cause, because this could indicate some underlying anxiety that she may not be connecting as anxiety. So those are those physical symptoms. Okay. And then how is she acting? What is she actually doing? This is another thing to pay attention to that helps us make that distinction, and often women want to make that distinction. Is this just normal postpartum? As we talked about, 50% to 80% of new moms have negative symptoms that continue for a couple of months. So if she's really trying to take care of herself over the course of 2 or 3 weeks, that's what self-care, over 2 or 3 weeks, and it's not working, she needs to be seeking professional help. If she isn't doing well with daily living, she's not able to sleep, she's not able to eat, somebody else is having to take care of the baby, she's not getting dressed every day. Another really important warning sign is that she can't go back to sleep even though the baby is sleeping. That indicates some need for professional help. And as we referred from the beginning, more bad days than good days. And of course, if she has any of the thoughts of harming herself or others, she needs some mental health intervention regardless of that. As we talked about these, is she avoiding the triggers? Does she feel driven to act? It doesn't really matter where she falls in terms of these questions. If she has the OCD or she has the psychosis, we want her talking to a mental health professional who can help her with that. And I apologize, my cat is meowing in the background. That's not a baby crying, that is my cat. Okay. And of course, we're going to have some impact on bonding and attachment. Moms with postpartum depression, particularly if they're having the obsessive thoughts, they're going to avoid connecting with the baby. Anxious mothering, of course, is going to influence the baby, and we're not quite sure. This can really go in both directions, that we get kind of a chicken and an egg question, or chicken and egg pattern going on. If you have a baby with a difficult temperament and a mom is not able to soothe that baby, then she's going to be really anxious about how to respond in terms of that. I think it's important in terms of bonding, though, to recognize that we are not like the bird world, where there is a window when you can attach, and you are all probably familiar with that, but that attachment can continue to happen across the first year, and we don't want to give up at any point if it hasn't happened, but we want to intervene as soon as we realize that there's a problem. What happened to my wording here? There we go. Okay, so more in terms of bonding and attachment, that dysregulated sensitivity, that she is not tuned into the baby's cues. If she is really depressed, she might not be able to realize when the baby has had enough. She might be contributing to the baby being stimulated. Or you can have a baby that isn't giving clues and a mom who is somewhat depressed, and so she is not picking up on those. It's another time we want to really pay attention to what's going on. And if she's showing just a lot of self-criticism, she doesn't seem like she is feeling good about herself at all. Okay, so I see that we need to move along a little more quickly here. So this can be the role of anybody who comes in conflict with or in contact with a new mom, and this is what you want to talk to the patient about is, we want to validate and normalize. How many women have this, how normal it is, that there's nothing the matter with her, that she can get help. We want to educate her about the various varieties of postpartum depression, and that just that term of postpartum depression is a bit of a misnomer, because many more women have irritability and anxiety than they have actual depression. We want to give support, which is our little joke about the bra here. Tell her that she can be well, she can seek support lots of places. www.postpartum.net is an excellent place to find support groups all across Texas, all across the country. There are online support groups, there are telephone support groups. We want to get her connected with those kinds of resources and reassure her that she will be well. Okay. All right, so you can probably all read that one, but that's just an effort to introduce a little bit of humor that we can't really prepare for what's going to be ahead. We have to instead kind of step in and deal with whatever does happen. So I like the poor parents there with the setting on terrible twos. This is the parenthood simulator to get parents ready, because we can't ever really know. But every woman, regardless of if she has depression or anxiety developing anyway, every new mom needs to think in terms of her self-care and that she has to take care of herself. And it's very much like, this is a picture, I wasn't sure that picture is clear, of oxygen masks. And most everybody is familiar with that. You're on the plane, the oxygen masks, if the oxygen masks drop down, the flight attendants tell us, you put your own on first, and then you help others around you. And that's what a postpartum survival plan is crafted to be, is the woman beginning to take care of herself so that she can be the best mom that she wants to be to her baby. So the factors that I'm going to talk about here, this is not medical advice, and I encourage people to check with your doctor. Okay, but this is basically the steps. She wants to take care of herself physically. That means good diet. That means a little bit of walking, even if it's an 8-minute walk can boost your mood. That means, a 10-minute rest, even if you can't sleep. She needs to be connected with some kind of support system. Maybe that's a breastfeeding support group. Maybe that's something through Postpartum Support International. Maybe that's a church group. Maybe that's her own family system. She needs to be able to attend to positive and negative feelings, that things are going well as that there might be stresses. I like to tell women to make a did-do list. A really good way to intervene is one day, write down everything you do for the baby, because what we do for children is often not noticed. She needs to take breaks, even if this is a break to just do some long, slow exhaling 2 or 3 times a day. She needs to keep her expectations realistic, that this is going to be a hard period of time, and this isn't going to be the time when you can get started on that novel you always thought you were going to write while the baby slept. That's just not how it works. Structure is really important, small bits of structure. This can be loosely defined, so sometime between 9 and 12 we're going to take a walk. Sometime between 1 and 5 in the afternoon I'm going to talk to another adult human being. Fostering sense of humor is really important in terms of healing. So does that mean partner needs to come home with a joke every day while she's on maternity leave? Does that mean one break that she can take is to watch a 20-minute show that's going to make her laugh? And finally, to postpone major life changes. If she doesn't have to move or change jobs or any of those things, it's better. Okay. So these are since we're running out of time, I'll just have that summary slide. Let me talk a little bit about some supplements. Calcium and magnesium are really important. Zinc is important. Omega-3s, fish or flax are important to brain health. A stress formula multivitamin, or continuing her prenatal. A probiotic. I'm sorry, I went too fast there. Probiotics we see are incredibly helpful with anxiety. Dietary changes to cut out NutraSweet, alcohol, caffeine, and reduce processed sugar. As I referred, an 8-minute walk can boost your mood. Relaxation or meditation, and hardly any new mom has time for like a 20-minute relaxation period. But if you can just stop and do long, slow exhaling for 2 minutes out of every hour, you're going to be considerably less stressed and anxious. Okay, so develop her support system, express and accept negative feelings. We can see this is a mixing bowl, or maybe it's not very clear, that has feeling names in there, because that's what she's got, is just a mix of feelings going on. Keep her expectations realistic. We are not June Cleaver or any other television character that might look like a stellar mom, or for that matter, celebrity. The celebrity culture is very influential that way. Oh, this is an example of the did-do list. that can often make her feel good. You just do that one day and then you put it up on the fridge and it counts her every day so that you can see what you are actually accomplishing. Okay, that she needs to take breaks. She needs to structure her day. She needs to foster her sense of humor, because sometimes things happen that it's just better to laugh than to cry, like this picture shows, and postpone major life changes if she can. Okay, so there's my contact information with my website there, a couple of my books, and I guess we're about out of time. There might be time for a question if somebody's typing one. Okay, so the question is, where can mothers go to receive support beyond medication that their primary care provider can provide? There are a couple of support groups in the Dallas-Fort Worth area. I include anybody to consult www.postpartum.net, because those are all free support groups, and the telephone support is free. There is a chat with an expert that is a couple times, that is every single, postpartum.net, thank you. There is a support group every single Wednesday. There's a support group for dads on Mondays, one time a month. So these are all free services that postpartum.net can get people connected with if people can't afford another kind of therapeutic support. And like I said, I am certain that there are a couple of support groups here in the Dallas area that actually meet in person, as well as sort of those online support groups. And no, I'm sorry, I don't give my slides of the presentation out. If you have specific questions that you want me to clarify, I can. Oh, good. Somebody put up in the Austin area. There's a great, that's right. Austin has an incredible community in terms of this that we don't seem to have in the North Texas area. So if any of you are from that area, that's great. Thank you, Shalene. Okay. Any other questions or things before we wrap up? Again, there's a contact form on my website if you want to email me and ask further questions. I can send specific pages like the postpartum survival plan. I'm glad to send that out to people to use. Yes, somebody says, learn more about appropriate modalities for treating some of these issues. Yeah, postpartum.net also has they are working on a certification for people who want to be able to work with postpartum people. And even without going through the certification process, you can attend their 2-day workshop, which goes into great depth on all of this. This is just sort of skimming the surface about what they talk about, and they talk about appropriate modalities for treating some of these issues in those 2 days. Okay. Thank you all.
Thank you all. As I just typed, I'm going to be sending out surveys within the hour. Thank you, Ann, so much. That was tremendous information. In the email I send out, I will make sure to include the link that Ann had given, as well as her website and contact information. I hope that you all have a fabulous rest of your Wednesday. Thank you.